This is Ms. Yeomans recording a lecture for the Pediatric exam for Clinical 2, MAT 211. In this chapter, we talk all about the pediatric exam, and if you are a mother and you have maybe even gone to the pediatrician's office with a friend or a family member, you know that this is very detailed and there's a lot of organized chaos that goes on. So let's begin here on the first slide, and I'm going to go through these rather quickly and talk about pediatrics. And basically this deals with the care and the development of children, as well as diagnosing and treating the diseases in children. And of course we know that the person that takes care of the children and specializes in pediatrics is that pediatrician. We have got some great pediatricians in our area. So what type of visits do we typically have for patients in the pediatric office? Well, there's two broad categories. The first one is a well-child visit. It's also called a health maintenance visit. And then there's also sick child visit. So let's look at the well-child visit. This is basically where we bring the child in, we evaluate the growth and development of the child, and we have that physical exam so we can see how things are going. So with this exam, we typically look at not just the health, but anticipatory guidance. But part of the exam goes through a history and physical exam, and that's with every well-child visit. And we're looking for anything that might be abnormal and trying to get a head start on it. So what is anticipatory guidance? Well, this is basically telling that guardian, parent, whomever, what to expect. These are things that the person should be anticipating is going to start happening as the child progresses in age and develops until they come and see us again. So what all is involved with the health maintenance visit for the patient with anticipatory guidance? Well, we talk about these very important things. We talk about safety, nutrition, sleep, play, exercise development, and discipline. Oh yes, that's one of my favorites. You know, we will definitely hear our pediatricians tell parents, no, don't let them get away with everything. They are the child, not the parent. We are to guide them in the right direction and show them exactly what they should be doing and guide them into developing good routines so they can be good, productive members of society. So let's look at the timetable that we look at for well-child visits. So we schedule those well-child visits at these intervals: 1 month, 2 months, 4 months, 6 months, 9 months, 15, 18, 24 months, and then after that it's on a yearly or an annual basis. So that allows us to see those children at the appropriate times during their first 2 years in order to get them immunized appropriately and to ensure that they are developing. So the other type of visit that we talked about, which was that second category, is the sick child visit. Typically this is for those times when the parents call in and say, hey, I think we have an ear infection, I think we might have the flu, this, that, or the other, but this is anything other than the well-child visit. So the patient has to be brought into the office, evaluated, diagnosed, and then prescribed a treatment. So some of the things that we will be responsible for doing is medical assistance during those pediatric office visits. Just like we would for our adult patients, we're going to assess vital signs, their weight, visual acuity, and then also assist the physician during the exam. As you can imagine, the older that these children become, the more mobile they become. They just simply do not have time to sit still to be evaluated. So sometimes it takes a little bit of coaxing to get them to sit still. So part of that is developing rapport with that child, and this is so we can develop some understanding with our children, so we know that they are actually understanding what we're doing and not being afraid of everything that's going on. they actually, and if they're not scared, they tend to cooperate better during the exam. So depending on their age, it takes special techniques. So as you can see here in the slides and in your textbook, toddlers and preschoolers, they like to have games made out of anything. So sometimes you can use a puppet, you can use different types of techniques. You probably have seen videos online of physicians making different games, even with injections. So that's pretty cool, gaining their trust. We really want to do that. And then a lot of times when we get to those school-age children, we have to overcome fears of basically things like instruments, like the percussion hammer, which typically you don't see in a pediatrician's office used much. But think about the tongue depressor, or what we typically call a tongue blade, applicators, or maybe the swab that we're going to use to do a culture on a wound or do a throat culture. All of those things look very scary because they don't know what they are. So sometimes it just takes a moment to explain what it is. I love to tell kids, look at this long Q-tip. Does your mom or dad use the Q-tips to clean your ears? Well, this is just the same thing, just on a long stick, and I'm going to tickle the back of your throat, or I'm going to tickle the back of your nose. Giving them a chance to see things. I even let kids have that tongue depressor after I'm done using it, saying, okay, do you see this popsicle stick? Do you like to make popsicles at home? I'm going to let you have this popsicle stick when we get done, and you can go and make the biggest popsicle ever. Whatever you need to do. They love to touch a stethoscope. They think it's really awesome. Even let them listen to your heartbeat or their own heartbeat. That tends to make them calm down. So we also look at, during the development of rapport, the different levels of understanding for children. You know that toddlers don't understand things that adolescents understand. So you've got to be able to relate to those children on their particular age group. And you don't want to try to belittle them, but you don't want to talk above them to where they just can't understand. Understand that your adolescents are going to be the ones that it's kind of hard to reach because they tend to not want to share so much with us. So, let's keep going. How do we carry babies? I know how I love to carry babies, and you do too, I'm sure. But we have to carry them in the proper fashion. So there are typical ways that we do in the office and that are safe and comfortable for the child. The first one is that cradle position, where you have the baby cradled against your body, and then you also have that upright position where they're kind of upright and their head's kind of right below your chin, if you will, in your chest. So the next thing we need to talk about is growth measurements. This is part of gathering the information to decide, are these pediatric patients growing properly? Are they on schedule? Are they failing to thrive, or are they thriving? Those are some hard words to hear if you hear that failure to thrive. So let's talk about what are growth measurements. Well, it's one of the best methods to evaluate the growth of the child. So we typically look at the weight, height, or length, and the head circumference up to age 3 of a child. And that's during the office visits, and we're going to plot that information on that growth chart. And I know that seems scary, but we're going to make it as easy as we can. So with the weight, we're looking at measuring in pounds, and it's going to tell us, does this patient look like they're gaining weight? Are they losing weight? Is it too much in either direction? And then we're definitely going to be using this information about weight to decide what is the proper dose for medicine for these children. If you've worked in sim clinic any with us, that's one of the things that we talk about with the children. Why are we measuring your weight and height? We want to see how much medicine to give you. We want to see if you're growing right for your age group. That's very, very important. So when we measure weight, of course, we're going to get this in pounds. For infants, we're measuring them in the recumbent position, and then the older children, they're in a standing position. If you remember, recumbent means laying down, right? So there's you a good picture to see how we're going to measure that infant. So then we move on to length and height. Length and height are measured for children to also growth or map their growth. It's not used for medication dosage, but it is very important to us. For the children, what we were looking for with those older children where they're standing up, but if it's an infant, they are in that supine position. So look at there. They're in the supine position. Remember supine? Laying on their spine. Then we move on to head and chest circumference, okay? So the head and chest circumference are very important, and they mimic one another as we learn a little bit more about those. So the head and chest circumference, we are going to map on that growth chart as well. So when we're measuring the head circumference, it's actually abbreviated HC. The biggest period of growth is noticed in that infancy. So we measure a head circumference in children under 3 years old, and we plot that on the growth chart. So you're thinking, okay, well, what is the norm? Because, some kids, they look like they have larger heads than others. So the normal range is between 32 to 38 centimeters, and we are going to measure in centimeters for the head circumference and the chest circumference. There is about a 4-inch increase in head circumference within their first year of life, which is pretty impressive. So we're going to be measuring this to see if they have either macroencephaly or micro. Do y'all remember those prefixes for terminology? I sure hope so. So that's big and small. Big and small. The chest circumference, which is CC, at birth, it is approximately 2 centimeters larger than their chest. Their head circumference is larger than their chest circumference, and that's a good little rule of thumb to remember. So we're not getting confused with, is it too big, is it too small? We want to make sure everything's just right on pattern there with that growth chart. The chest does grow at a faster rate than the head, so between 6 months and 2 years, we're going to see some head circumference changing there. Okay?